Good afternoon. I'm very pleased to introduce to you Joe Vearey, who is an associate professor at the African Center for Migration and Society at the University of Witwatersrand in Johannesburg. She's responsible for a broad range of work in migration and health, including social determinants of health, HIV, sex work, and local level responses. She's a leading research in the area. She's also involved in postgraduate teaching, supervision, and research on issues related to migration and health. It's with great pleasure that we have her here with us to learn a bit more about her work.
Thanks very much for the opportunity. I'm planning on talking for about 20 minutes, and really the idea today is to try and, I suppose, provide a very broad overview on migration and HIV, and towards sort of exploring linkages between both migration, population mobility, and HIV, and to think through responses. So today I've decided to take a broad brush approach, and I'm going to try and map out what I think are key considerations for, I'm assuming, a range of people involved at different levels here, including programmers, including policymakers, including researchers. Now, something that I've found in my work, which has predominantly focused on Southern Africa but appears to resonate globally, is that understanding of migration is sadly quite poor within sectors that are primarily responsible for developing appropriate responses to HIV. And unfortunately, what we see at a global level are a range of negative and unsupported assumptions relating to the prevalence of cross-border migration. So there is an assumption that there are many hundreds of thousands of cross-border migrants. We see assumptions associated with between migration and the spread of disease, and an assumption that migrants place an undue burden on receiving healthcare systems, particularly in a public healthcare setting. So there are, of course, exceptions, and we know that there are good examples globally of where, particularly looking at regions, certain stakeholders have come together to develop connected responses. But broadly speaking, we see that public health responses do fail to address internal mobility and cross-border mobility, and we continue to see non-nationals facing challenges in accessing healthcare. So I argue, and I think others working on the subject would agree, that we really need coordinated, evidence-informed responses that consider migration, various forms of mobility, and HIV, and that these are going to have both developmental and public health benefits for all who are involved. So there's 4 key messages that I'd hope to send you all away with today, and as I say, I can't cover everything, and so the idea is to really just raise some key issues. The first message is that migration is a global norm, and it's something that we need to be considering in all health responses. There's a movement that many of you are familiar with where we talk about health in all policies. And I would argue we also need to be thinking about migration in all policies, particularly in relation to health. And this is because migration is a key determinant of health, and we know it's an important structural driver of HIV, and we're going to talk more about that. But what I'd like us to do is really think about the work of the Commission on the Social Determinants of Health and the work that you're all involved in around structural drivers of HIV, and to think about where population mobility and migration fits. As I've already mentioned, current responses to HIV don't adequately engage with mobility. And as I said, there are key examples which would counteract that. But predominantly speaking, our responses don't consider the movement of people, and when we're thinking about prevention, when we're thinking about treatment and support and well-being. And as a result, we need improved responses. To start with, to sort of set the scene, is that I really want us to think about these determinants of health and to think about the fact that for many who move, movement is into or within and between urban spaces. And this is something that is often omitted from discussions on migration and health, is that the urban space becomes very important. Now, I'm not going to focus on that today, but I would like us just to bear that in mind when we're thinking about the context. Importantly, what we are seeing at a global level, and we're seeing this playing out at a local level, is that there's an increasingly negative response politically to the movement of people across borders. And what we're seeing is increasing securitization around border areas, and the result is a range of negative consequences for those who move. This is because those prevailing assumptions around the need to keep the foreigner and the migrant out of a nation state transfer and trickle down to the way in which healthcare is delivered to them. So globally, around 3% of the world's population is a cross-border migrant, so somebody who is living in another country to which they were born. And what we see is this sort of 3% being reflected across the globe. And so regardless of where in the world we find ourselves, we will see that on average, around 3% of the population is a cross-border migrant. Now, obviously, this is going to increase at certain points near border areas, for example, and in some cities. But at a national level, in a country like South Africa, for example, which is often assumed to have a very particular form of mobility and migration, we see that just over 3% of the country's population is a cross-border migrant, so reflecting global norms. What is important is the number of internal migrants. Now, this is individuals who move within a country's borders. And when we talk about migration, we often make the mistake of only talking about these people here who cross borders, which many of us have done, and we fail to think about the other health and developmental effects associated with the movement of people moving within a country. Importantly, for the majority who move, migration isn't a random choice. Now, we know that there are certain situations in emergency settings and so on where that choice is very limited and individuals might be forced to move. But the majority of people who move are highly organised, and they make plans to move, and they move along very well-known routes. So I would argue that given that we know this and we're able to, as for example here, map out the major routes where people move along, why don't our health systems responses respond adequately? What I want to do is just quickly show us some of the complexity globally when we're thinking about mobility around linkages to the urban space. This is data here from 2009, when we saw just over half of the world's population now living in urban areas. Now, this slide gives you two things. If you look at the shading, the darker the country's shading, the higher the percentage of urban population it has. So the more urban a population at a country level. And the red dots and the yellow dots represent different urban agglomerations, the different cities and the sizes of cities. So if we look and then we move across to projections for the year 2025, you'll see that in the first instance, there tends to be darker shading globally. So populations are becoming more urban. But importantly, what we're seeing is we're seeing an increase in the number of the red dots. So when places urbanize and people are moving to urban areas, they're not necessarily moving to one or two cities and those are growing. They're also moving and establishing new urban spaces. And this is another dynamic that we need to be layering onto our ways of thinking about migration and HIV. So migration, we know, is increasingly recognized as a determinant of health. And what's important is to recognize the bidirectional relationship. So the way between when we're thinking about migration and health, that migration can determine health, but also that health can determine migration. So what do I mean by this? Well, I mean here that people who move might end up with a different set of health in relation to HIV, vulnerabilities or risks, and it might perhaps negatively impact their health. Equally, somebody might move from an area where healthcare access is poor, where perhaps there is no access to prevention, and they move somewhere where that situation changes, and as a result, their health improves. So this is where we're seeing migration affecting health. But equally and increasingly, we're seeing how health affects migration. And what I mean by this is that to move, people predominantly have to be healthy and well and fit. However, what we are seeing, particularly in the Southern African region, but data is supporting this elsewhere, is that if an individual's health status falls and they become sick, they become too sick to work, for example, they become ill, they're likely to return home to where they came from, to where their home, where their place of origin, their family and support networks are. So this is an example of where we're seeing how someone's health status can influence the decision to move. Either you're healthy and you're moving in search of improved work opportunities, you're going to study to join family, or your health deteriorates because of the context you're now living in, and as a result you return home. In 2008, the World Health Assembly passed a resolution on the health of migrants. And this was a very important document that was led through the leadership of a Spanish and Portuguese group who were at that time chairing the assembly. And this piece of legislation, this agenda item and the consequent resolution calls on member states to promote equitable access to health promotion, disease prevention and care for migrants. And really this was a result of the fact that several southern European states were receiving large numbers of non-European migrants, predominantly migrants from elsewhere on the African continent who were moving through southern Europe en route to Central Europe. And these countries were recognizing that their current responses were struggling to deal with mobility and migration and the needs of those who move. So in order to recognize this and encourage a conversation globally and encourage all countries that engage with mobile and migrant populations, these 4 priority areas were identified. And it's around monitoring, it's around developing partnerships and networks to respond to the health needs of migrants and people who move. It's about improving the way health systems respond and thinking through our policy and legal frameworks. This resolution predominantly focused on health broadly and didn't specifically focus in on HIV, and it predominantly focused on the context in Northern Europe. And so I think some of us have worked quite hard to try and see how we can use this as a tool for advocacy to improving thinking about mobility and migration and responses in our own regions, for example, in Southern Africa. What's important is to recognize, as I've mentioned earlier, that health seeking is often assumed to be a reason for movement. We often assume people move into urban areas across cities, for example, because they're sick and they're trying to access improved care. But evidence suggests otherwise, and we know that the majority are moving in search of improved livelihoods, and to do this, they need to be in good health, as I mentioned. So this phenomenon, the healthy migrant effect, is a common observation where we see recent arrivals in better health than a local population to which they arrive. And this is reflecting the positive selection of migrants. As I mentioned, to move, you need to be healthy. When we look at this in a context of HIV, we see, for example, individuals are perhaps moving from an area of perhaps a low prevalence of HIV to an area of a high prevalence of HIV, or from high to low. And this is going to shift their HIV risk profiles as they move. For example, if somebody comes from a region where perhaps there is more HIV, perhaps they are better educated and aware of risks around HIV. It also might mean that they themselves are living with HIV or on treatment and are moving. And what we need to think about is what happens when individuals move and they find themselves in a particular context that may lead to a deterioration in their health status. And so this health benefit we see associated with migration wearing away. So we see that mobile populations and people who move and migrants sometimes find themselves living in particular spaces of vulnerability, is what the International Organization for Migration calls them. And this is where we see that different contexts in which somebody who's moved now finds themselves might lead to an increased risk of acquisition of HIV. I would also argue that this movement and these so-called spaces of vulnerability also will have a negative impact for somebody who's currently living with HIV. So, for example, if you're living with HIV and you're on treatment, when you move, it might become very hard to continue your treatment, for example. It might be that you move somewhere where you're no longer able to access healthcare or a good diet, and that's going to have certain consequences to your health and well-being. And it's important when we're thinking about HIV that we think about that broad spectrum around health and well-being and obviously around structural drivers. So the IOM has created a schematic, I'm just trying to move slides, thanks, that refers to different phases in the migration journey. Now, whilst this is in some ways quite a limited sort of view of what's happening, it's a very useful tool in helping us start to map out what happens as and when individuals move. And I would argue this is very useful for mapping out issues around prevention, treatment, care, wellness in relation to HIV. So, for example, thinking about what is called here the pre-migration phase. So before somebody moves, what's the context? Where are they living? And importantly, thinking about what is known as the epidemiological profile. So this would be the local context in relation to, for example, communicable disease burden, looking at, for example, incidence and prevalence of HIV, as well as other health conditions. The movement phase, this is when people are on the move. Now, a key factor here is the duration of the journey. For some people move very quickly. They perhaps travel by an aeroplane or on a prepaid bus, and they get to their destination quickly. For others, it's a much more protracted period of time. And what we start seeing is that during this process, conditions around travel and the context individuals find themselves in may put them at increased risk of acquiring HIV, or if they're living with HIV and are well and on treatment, perhaps increasing their risk in relation to other continuity of treatment and issues related to that. When an individual arrives, for example, where they're planning to move, there are a whole range of contexts that they may find themselves now facing. And a lot here is related to the legal framework. So when we're thinking about structural drivers, there is something about the socio-political context and around how migration and health are governed that is going to affect and influence how an individual arriving in a new space is treated. Are they able to easily access continuity of care? Are they able to access prevention modalities and so forth? Importantly, we see issues around legal status, which is important for those who cross borders. Increasingly, as I mentioned earlier, through increased securitization processes, it's becoming harder for lower skilled workers, particularly job seekers, to regularize, so be legal. And the result is that there are individuals without documentation. Now, this has a whole range of impacts in different contexts depending on whether documentation is demanded at the point of use of healthcare. And we see this being a huge barrier to healthcare and well-being for many. For some migrants and some people who move, there's then a return phase where they return home. For some, this is a cycle that will keep repeating throughout the year. For some, it might be over a period of several years. But what happens when somebody returns home is that they're moving from a particular context here to another context back at home. And this context might be different and might affect how somebody has previously behaved at home, and they might be exposed to different things in, for example, the city. This might change their behaviors over time. So how does this then affect those who didn't move and are remaining at home? And there's obviously a broader range of cross-cutting issues we need to think about in relation to differences between the age of people who move, the gender of people who move, I would argue the kind of work people are involved in, and so on. I'm anticipating that most of you know the following slide very well, so excuse me for using it, but I think it is important to reference the Southern African Development Community think tank meeting that took place now quite a few years ago in 2006. Where thinking through issues around the different drivers associated with HIV were discussed. I'm sure that this has moved on in different ways, but I find it a very helpful schematic for thinking about where these broader structural drivers that are related to social processes, such as population mobility, fit. And I would argue, and I know it's the work of Strive in particular as an example, that this is where we need to be focusing much of our efforts and much of our work. And it's not just around thinking through prevention and treatment as prevention, but it's thinking about the wider well-being of individuals who move, thinking about why they move and what comes here and what drives these processes. So I would urge those of us that are perhaps working at this level, and I'm sure it's something that many of you in particular contexts come across in your research and in your clinical practice and in your programming, that people don't stay in one place. Many of us move. Many of us go different places during holidays, if we're feeling well, if we have to return home because a family member has passed away or so on. And we need to find a way to program this mobility into all of our other kinds of programs. Now here what's important is that we've talked about mobility and movement as a potential driver of HIV. Now, it is true that the movement of people links separate spaces and different epidemics, and there is some argument and early literature when first looking at migration and HIV that suggests those who move are engaged in riskier sex. There is a range of literature that clearly indicates that migration is complicated. It's not one thing, and we could have many hours discussing all the different forms of mobility and reasons for people moving. And it's important that we recognize that when we move, and I'm somebody who moves quite a lot, and I'm sure there are others here, is we pick up different characteristics and behaviors from different places, and we take those with us. And those characteristics and behaviors might not be known in the place we're now at. So when we're thinking about programming and policy and responding, we need to think about where our population may have come from and how these characteristics might influence our behavior around healthcare seeking, around prevention, around treatment, and so on. But the biggest issue is when we're thinking about migration HIV, there is a range of conflicting evidence. And increasingly we're seeing a suggestion that mobility isn't driving epidemics, but what it is doing is it's creating ongoing healthcare challenges as we're seeing HIV as a chronic condition. We need to think about this association. We need to think about contextual changes along the migration journey. And we need to think about how social processes and relationships affect that. I'm aware that my time is basically up, but what I'd like to just very quickly do is just close with 2 slides. And just to remind us that given that current responses aren't adequately engaging with population mobility, what do we need to do? And I found this quite interesting because in this particular image I discovered, there's no mention when we're thinking about HIV around mobility or around mobility or migration. And I would argue that's something that I would like to be seeing in big letters on this slide to help us when we're thinking about our responses. Again, I'm sure that there are many of you who are familiar with this idea of highly active HIV prevention. So what do we think needs to be done? Now, as I've mentioned, responses are lacking, and a big issue for me is that understanding around mobility in a context of migration is problematic. And I would argue that what we need to do is go back to thinking about these different layers that come together to help us towards prevention, and I think one could apply the same thing to thinking about treatment and well-being. And it's about moving beyond the immediate drivers, and it's really about thinking about the fact that we need to be looking importantly at leadership at different levels, and I would argue that without engaging at a global level around the realities of population movement and the politics behind it, a lot of our local level responses will struggle. What is needed? So I would argue, and it's been, I'm not sure in 20 minutes if I've confused you more than I've laid out some ideas, but my argument would be we need to be applying a social determinants of health lens, and importantly we need to think about where people work as well as where people come from and where they're moving to. A social determinants lens helps us think about those broader structural determinants around immigration and migration management, around securitization of borders, and around the ways urban spaces grow. We need better data. This is always something that many of us are asking for, but I would urge those of you involved in designing data collection systems for health information systems within research studies and so on to be adding variables for measuring migration and mobility. These can just be a few variables that are just added into a standard questionnaire. We need to be advocating for a migration-aware public health, and I would argue that this is the key issue that I was talking about on the previous slide when thinking about the need to think about politics. And why is it that we are so uncomfortable talking about migration when we're talking about health? And importantly, trying not to exceptionalize cross-border migrants. People who move within inside a country are far greater in number, and our data indicates that it's often those who move within a country who are more at risk of acquiring HIV than those who move across borders due to the positive selection of people moving across borders. So I'm going to leave it there, and I look forward to your questions, and hopefully we'll have time to discuss everything that I've skipped over. Thanks.
Okay, thank you very much, Joe, for this most interesting talk. You've covered so many aspects of the dynamics of migration and its influence on health, and especially HIV. It was very enlightening. So I would now open for questions.
I talk about internal migrants being a greater development challenge to governments, and this is in terms of a whole range of issues, but including thinking about health needs and health planning and health systems and public health. The reason is that in many contexts where we are seeing the greatest increase in urban growth currently, which tends to be in Asia and Africa, what we're seeing is that states are quite poorly equipped to deal with the growth of urban spaces. And a lot of this growth is associated with the movement of people. And the result is that we end up with a situation where people who are moving internally are not being considered in the development of planning responses and of, for example, building new healthcare facilities or trying to work out how much it's going to cost to fund improved housing and sanitation. So responses tend to be based on outdated numbers, based on a smaller population size. And the result is that we end up with groups of individuals who've moved, who are larger in number, which is internal migrants, who are omitted from these responses.
Okay, I have one question also about internal migration. So I often see that there is a lot more focus, a lot more attention driven towards cross-border migration. And you mentioned that it would be urgent to dedicate more prevention and policy efforts to internal migrants. And in our work, we often find it's not necessarily very easy to identify internal migrants in the population, and the issues and barriers for access are often not the same. Have you given it some thought? How is, in your research, what have you come across?
In terms of the difference between, so in identifying internal migrants and
addressing their healthcare needs.
Yeah. I mean, I think an important issue is that obviously every context is going to be different, and so in different spaces, the needs are going to be different. We're thinking about different epidemiological profiles. We're thinking about slight differences in migration flows and patterns. But what we've seen in our work, particularly in South and Southern Africa, is that it is possible to identify people who've moved internally. And quite a lot of the work that we've done, where we've explored the differences between cross-border migrants and internal migrants, so for example in South Africa, people who've moved from other areas of South Africa. And what we see is that the health needs of the people who've moved internally tend to be greater. They tend to be living in more difficult contexts. They tend to be, for example, their diet tends to be worse. They're less likely to be earning an income. They're hungry. They have more dependence. They struggle to access healthcare, and so forth. So I think that if one designs research to explore and to examine the differences between internal and cross-border people who are moving, I think that it is an important factor that many research studies continue to omit when we're thinking about migration. So we continue to perpetuate this idea that cross-border migrants are more at risk, for example, around HIV than those who move internally.
Okay, thanks. We have another question. He's asking Jo if she has any experience to share about gender inequity from a gender inequity lens in migration and HIV. It's a question from Delhi.
Yeah.
Jo.
I think that in a way it is about thinking about the way that other research responses, program and policy around HIV should be engaging with gender inequity, and I would argue that migration is an extra layer to that. So it's a dynamic that we need to be embedding in our responses. It's not about developing a whole load of new programs, for example, to deal with migration, and I would argue that it is about thinking through where we're thinking about issues around equity and equality, or inequity and inequality. We're thinking about where does migration fit there. And as I mentioned, we often assume that people who move are worse off than those that don't move. But when we start looking at all of the different types of people who move, we start seeing quite big differences. So a woman who moves in one way might be different to a man who moves in another way, who might be different to a transgendered person who's moving and seeking treatment, for example. And so I think it is about recognizing diversity in people's experiences and people's needs, and including that within our programs.
Thanks. So we have another question here from Annick Borges, asking if Are there success stories of good management of migration in a country setting where internal or cross-border migration is common?
There are definitely some good success stories. The challenge is that many of these tend to be at a very small scale, at a single program level, often in partnership with organizations like the International Organization for Migration. So, for example, there's good practice in Southern Asia, there's some good practice in Southern Africa. But the big challenge is that these tend to remain very localized and that they aren't connected to bigger changes in the policy context and in programming. So I think that there are a lot of lessons learned that we need to be working to upscale. And I think that a lot of these lessons are about where there are good cross-border relationships developed at a local level. So, for example, where you have populations who live either side of a border, perhaps one side of a border has improved healthcare facilities compared to another. And those two areas, those two regions, develop systems for sharing healthcare facilities, for example. I'm happy to direct you to, there's some good material available from the IOM where they've evaluated these kinds of interventions. But unfortunately, when we're looking at levels of responses that are funded and directed at national and at regional levels, they're much more limited.
Okay, thanks, Jo. We have another question from Imara Roston. Greetings, Jo. Do you see any potential connections between social justice-oriented community mobilization and economic policies that induce migration? Are the distance between internal migrant voices and decision-making bodies too great?
You see, the issue around what it is that causes and drives migration is a big factor, and it's something that absolutely needs to be considered. And it's the causes of the causes and the drivers of the drivers. But we also have to recognise that people move for reasons that are also not only associated with economic policies. A desire to see something different and be somewhere new, and assuming that there could otherwise be a static population, I think is problematic. So whilst I agree that there is a need to think about why people move and why in some contexts people are moving because, different structural policies and adjustment programs and so forth are leading people to need to move, we're always going to have the situation where people want to move and want to explore different contexts. And I do think that we are slow at connecting, conversations between healthy economic development, as it were, and health for all. And I think that's a big gap. And I think migration provides an important lens, I suppose, to looking at some of these issues. Looking at the experiences of individuals who move and why they're moving. And it shows how connected we are all to these broader global policies and changes and so on. And I do think that there is a distance between people who move internally and decision-making bodies at various levels. And the main reason is that I still don't think internal movement is seen or recognised or considered to be an important constituency when thinking about responses. And I think that's the main reason that there is such limited voice from those groups within policy making and decision making and advocacy spaces.
Okay, thank you, Jo. Do we have any more questions?
Well, there was a question I saw earlier up on the little chat thing that I think we missed.
Go for it.
So it's a question from Paul Mee, who asks about how a national healthcare system in a country such as South Africa can adapt to better meet the needs of internal migrants. And for me, it's about the fact that it's almost impossible to move between different healthcare facilities. If you're registered at one facility and you travel somewhere else, whether you're returning home for the holidays, whether you're moving for work, it's impossible to pull up your medical records. And what I think we need something like a form of a health passport, which is sort of like a road to health card, I suppose, or a patient held record in some formulation that would allow somebody to move clearly with, an indication of their particular health needs, particularly around HIV, treatment history, something that's very simple that can be moved within a country, go to different facilities and be able to continue treatment, for example. But importantly, within regions where people move, I think it needs to be expanded to also cross those borders. And we need to remember this isn't only about HIV. We see this with, for example, a pregnant woman in the city might choose to deliver her baby back home in another area. And it's very difficult for her to then register when she arrives in that area to give birth, and it's very problematic because it's assumed she would have stayed where she had become pregnant, for example. And we need to think about that disconnect. If we know that socially, if we know people move, as I said at the beginning, our health responses should be able to engage with that movement.
So I'd like to thank Jo Vearey very much for the talk. It was very interesting. That covered many aspects of the migration, internal cross-border migrations, the influences on health, HIV, drivers, and how the policy responses are being articulated to this very important and urgent questions.